I'm Anirban Basu. I'm a professor of health economics and the director of the Comparative Health Outcomes Policy and Economics Institute at the University of Washington in Seattle. I have been working on establishing the value of health technology here in the US for about 2 decades, and I'm very glad to be part of the CEIA initiative to understand the value of gene therapy for sickle cell disease. We think our work is important for the patients with sickle cell disease because it gives them the long-term impact of these therapies on their lives that are not revealed in the clinical trials that was done. It also establishes the correct information on the economic impact of these therapies so that these therapies could be priced appropriately so that they can be easily accessible to all patients. The CEIA, or the Clinical and Economic Impact Analysis Consortium, was established as part of the bigger NHLBI-led effort of Cure Sickle Cell Initiative, which aimed to kind of accelerate development of gene therapies to cure sickle cell. The goals of the CEIA was to establish long-term benefits and cost of gene therapy compared to standards of care that patients receive today. NHLBI funded 2 groups, one led by Dr. Scott Ramsey at the Fred Hutchinson Cancer Center, and the other led by me at the Choice Institute here and the School of Pharmacy at the University of Washington in Seattle. The goal was that the 2 groups would collaborate and share data assets and resources, but come up with 2 independent mathematical models that would establish the long-term economic impact of gene therapy in this population. The National Heart, Lung, and Blood Institute funded 2 groups. These groups both had investigators spanning disciplines of economics, decision sciences, medical sciences, and outcomes research. The goal was for these 2 groups to collaborate and share data assets and resources, but develop 2 independent mathematical models to establish the long-term economic impact of sickle cell gene therapy. As we embarked on our mission, we quickly realized that there was a dearth of evidence, even basic evidence like the burden of disease in this population. Over the last 4 years, we have published over a dozen peer-reviewed articles filling in this gap, including a landscape analysis on various topics on this patient population, and culminating in a paper in the Annals of Internal Medicine, where we showcase the long-term economic impacts and the value-based prices for sickle cell gene therapy. Well, we followed the good practice guidelines established by the Society for Medical Decision Making and the International Society for Pharmacoeconomics Research Task Force on Economic Analysis. This involved engaging a variety of stakeholders, including patients, caregivers, physicians, and researchers, to understand the disease better and develop our conceptual model. We then followed it up with a rigorous approach to develop mathematical models and calibrate that model against data from the population of individuals with sickle cell disease who are covered by the Center for Medicaid and Medicare Services insurance plans. Finally, we took the short-term evidence on gene therapy from the clinical trials and used our model to forecast the long-term benefits and cost and compared them to the experiences of the patients under the standard of care that they receive today. Our Annals of Internal Medicine study showed that gene therapy could extend the life expectancy for the eligible group of individuals with sickle cell disease by almost 17 years compared to common care that they receive today. In addition, gene therapy could reduce the number of pain crisis events by 70 or 80 events over the lifetime of the patients. Now, this would naturally translate to improvements in the potential for patients getting long-term employment, improvements in their quality of life, improvements in the quality of life of their caregivers and their time cost. These results were fairly consistent across both the models that we studied. The Fred Hutch model concluded that any acquisition cost of gene therapy below $1 million should be cost effective. The UW model concluded that any price of less than $2 million for gene therapy would be cost effective. The differences in these two models could be attributed to slight differences in the model structure, the comorbidities that were considered, and finally the target population that these results generalized to. One of the unique features of our models was that we had to consider a breadth of comorbidities and their incidence and prevalences over time, given the large burden of these comorbidities that these patients face. We also calibrated our model against the outcomes data for the population of patients with sickle cell disease in the United States who are covered by the Center for Medicaid and Medicare Services insurance plans. So which gives us confidence that our results are quite generalizable to the patient population in the US. And finally, we followed a societal perspective, which is often not followed in cost analysis. Ignoring societal benefits like employment opportunities and caregiver burden would vastly underestimate the value of gene therapy. The UW measure, which is the model that we named for our mathematical model, is a microsimulation model, which means that we take each patient and pass them through the model one at a time. We are able to establish treatment effect heterogeneity over a large number of comorbidities and demographic characteristics. The model embeds a variety of machine learning models to predict the incidence of comorbidities and mortalities as patients age, and we were able to validate these predictions based on an independent holdout sample of patients with sickle cell disease. The Fred Hutch model is a cohort model, which means that it takes a cohort of patients with sickle cell disease and passes them through the model at the same time. It also allows for certain specific subgroups to have differential rates of progression and have different incidences of comorbidities. The predictions from this model were also validated against an independent sample of patients with sickle cell disease. There were differences in how the effect of gene therapy was incorporated in these models. The UW model assumed that gene therapy will achieve the survival rates that are documented under matched sibling transplantation data. The Fred Hutch model assumed that the survival benefits of gene therapy will come from muting the incidence of comorbidities in future time periods. The UW model also considered a slightly larger number of vaso-occlusive events, for example, acute chest syndrome, and was able to establish heterogeneity in different cohorts of sickle cell patients, those who are enrolled in Medicaid versus Medicare versus those who are dual eligibles. We are very open to collaborating with anyone who is interested in developing cost and benefits estimates for their purposes. For example, we are currently working with Dr. Stacy Arnold at Emory University to establish the cost effectiveness of gene therapy compared to matched sibling or haplo transplantation. Because we are not allowed to share the individual level data, it's easier for us to run the model from our side to the extent we have the time and resources. But we are very open to collaboration. So the R Shiny platform is a web portal that was developed to understand how the UW model results will vary if you change some of the input parameter values. It allows users to study sensitivity of the final results. So the user goes to this web portal, selects the parameter that they want to change, selects a low or a higher value, and then projects the new results and compares them to the base results that they want. The R-Shiny website will be available through the research page at the Choice Institute and also on the Cure Sickle Cell Initiative webpage, which is curesickle.org. All they need is familiarity with the Annals in Internal Medicine paper, so they understand the basic premises of the results that are presented there. The website is very easy to use. It has a drop-down menu that allows you to select the input parameter that you want to change the value for, select the low or the high value, and the results automatically appear on the website. Now, because mathematical models often make assumptions about the input parameters and the values of those input parameters, researchers, policymakers, and other clinicians and other stakeholders may find that for their population, those input parameter values could be slightly different. So this would allow them to study the final results, but selecting an input parameter value that most catered to the population that they serve. We hope that our results can inform the Center for Medicaid and Medicare Services to figure out the appropriate acquisition cost of gene therapy so that these therapies becomes accessible broadly and equitably to the patients with sickle cell disease. The final price of gene therapy will depend on discussions across various stakeholders, including policymakers, clinicians, and patients, as it needs to balance various aspects such as affordability and budget impact, and also promote competition among the manufacturers of gene therapy. We have a Choice Institute research webpage that will link to all of the peer-reviewed articles and the entry to the R-Shiny platform. These resources would also be available on the Cure Sickle Cell website, which is the curesickle.org.